Okay, this is the last lecture in our cardiac series. So after this you will know everything that you need to know and then some about basic introduction to cardiology. Okay, so we are going to do chapter 29, and in chapter 29 it's all about complications that can occur because something is wrong with the heart. So these complications can occur from the cardiomyopathies that we've talked about. They can occur from infectious processes, valve problems, heart attacks, coronary artery disease. Any of those problems can lead to these complications that we're going to talk about. The reason being, you need an efficient, well-running cardiopulmonary system in order to have everything else in the body work. So if you have a problem with your cardiopulmonary system, you're going to have complications. And this is a very prevalent problem in the United States, which is why this is so important for you to understand. And we've touched on most of the stuff in the previous lecture, so hopefully this will be review. Basic review, you've got the right side of the heart. The blood comes back from the veins, drops into the right atrium, goes into the right ventricle, goes into the pulmonary artery, goes to the lungs where it picks up oxygen, comes back through the pulmonary vein, dumps into the left atrium, dumps into the left ventricle, out through the aorta to all parts of the body with oxygenated blood in the arterial system. When the pump is not working, there's complications. The most common cause is ischemia. When ischemia occurs to the heart muscle, that heart muscle, the cells in there die. And they can no longer contribute to the workload of the heart. And I've mentioned this before. This is like a team of 6 horses pulling a heavy cart of something, and then one of the horses dies. And you still have to get the cart there with that load, but now you have less things, less helpers, less horses to do the work, so the other horses have to pick up, and that's what occurs when there's a complication in the heart. In the case of the cardiomyopathies, the same concept occurs, that even though it's not ischemia, it's an ineffective cardiac muscle. So any time, for whatever reason, if that muscle is not efficient, you're going to have problems. In the event of ischemia or a myopathy where that muscle isn't working, and if that occurs on the left side of the heart, you are going to have left-sided heart failure. You'll also hear this called congestive heart failure. A lot of people refer it to as congestive heart failure, and then it got moved to left-sided heart failure, and then they call it heart failure. Technically, it's left-sided heart failure. The problem with left-sided heart failure is that this left ventricle is supposed to be ejecting blood through the aorta out to the rest of the body, but because it becomes inefficient, there's 2 things you're going to see going on. One, you're going to see some problems in the pulmonary system, and this is because those horses, the 5 remaining horses, are getting a little tired. And so they just move a little slower. It's harder for them to get the cart there. And so things start backing up. So as the blood comes into the left atrium, tries to dump into the left ventricle, and all of this stuff is trying to shove it out into the aorta, it just starts getting tired, and it's inefficient, and it's not as strong of a contraction as it used to be. And if you'll remember, this is your cardiac output coming out of the left ventricle. The cardiac output should be between 4 and 8 liters per minute. When your cardiac output starts getting reduced, you still have 4 to 8 liters of blood in the system. That hasn't gone anywhere. Unless your patient's bleeding, they still have this amount of fluid in the system. And what happens then is it fills up in here, but it can't get it all out. That's your ejection fraction, is how much blood is ejected with each beat. And what you'll see happening is that ejection fraction will start dropping. So, typically you like to have between 60 and 80% of the blood ejected with each beat. Like 75 to 80% of blood ejected, that's a really good ejection fraction. But when this ejection fraction starts dropping, and it can get pretty low, 35, 40% ejection fraction, that means every time this heartbeat, the ventricle contracts, less blood is getting out into the aorta. It's a reduced ejection fraction. That's a reduction in your stroke volume, and hence then a reduction in your cardiac output. So you're going to start seeing symptoms of a reduced cardiac output, reduced ejection fraction, reduced stroke volume, and you're going to see things like whatever organ is waiting for the oxygen to show up, you're going to see problems. So you might see like restlessness, confusion, irritability because the brain is not getting as much oxygen. Fatigue is common because of lack of oxygen to the organs. Inability to be as active, like a patient who used to be able to walk up a flight of stairs, now they have to stop halfway up and catch their breath because of anemia and lack of oxygen and a reduced cardiac output. The other thing that starts happening is because there's more blood in here, and if you'll recall, the blood that's in the ventricles at the end of diastole, that's your preload. So this is all filled up with your preload, but now this blood that's coming back from the pulmonary system in the left atrium is trying to dump its blood into the left ventricle through our little mitral valve there. Well, the valve opens up all of a sudden. I still have a lot of blood in there, so you can get some blood back from that left atrium, but the rest of it is just starting to get backed up. Then your left atrium fills up, and then ultimately this fluid then starts building back up into the pulmonary system. This is why your patients who have left-sided heart failure also have pulmonary problems. They can have rales, crackles, fluid in their lungs, dyspnea. They may have to sleep on pillows. It's hard for them to catch their breath because in addition to having a reduced cardiac output, they also have fluid in their lungs because it's getting backed up. So you want to watch for your patients who have these cardiac problems that we talked about. That's why it's especially important to monitor their pulmonary status and what's going on in their cardiac output. So all of this, if you recall, all of this fluid in here is called preload. So one thing that you can do to fix this problem is reduce preload, reduce volume. So one way that you can do that is put a patient on diuretic. Then you're just removing some of that fluid, and you've offset having extra fluid in the system because the system can't accommodate it very well. So that's one thing that you can do, and it's a fairly common treatment for patients who have left-sided heart failure. And I'm going to spend a little bit of time talking about the drugs that we use to treat heart failure because it's important to know. So one way to do that is to reduce preload. Another way to do that is to reduce afterload. And if you remember, your afterload is the amount of resistance that this left ventricle meets when it's ejecting blood into the aorta. here. So if you can reduce the afterload, you are dilating those arteries. So if this is your regular aorta, that ventricle is contracting, if you reduce your afterload, you're increasing the diameter of that artery, you're causing vasodilation, and you've reduced afterload, you've reduced the amount of force that's needed. So now you've opened this up, so this ventricle that has some kind of damage to it, when it contracts, it's meeting less resistance and it can get more blood out. So that's another way, is to put your patient on a medication that will reduce afterload. So you want to reduce preload and you want to reduce afterload in your patients who have left-sided heart failure. And the other thing that you can do in this patient is to give something that's going to increase the contractility. And this is DIG. Digitalis is a phenomenal drug. It's been around forever, but it is phenomenal for increasing the contractility of that heart. So patients are often put on a combination of drugs like a diuretic and like Digitalis, something that's going to increase contractility, maybe reduce afterload. And another thing, the beta blockers are great drugs because that will reduces the heart rate, it reduces how fast that heart is beating, which now you've reduced the work of the heart. And so then the demand on that muscle has reduced. Anytime your muscles are doing less work, less oxygen is needed. That's why resting your patient is so important, is because you're not requiring as much energy and less oxygen. So that's what the beta blockers are really good for. I do want to mention, and I think I saw this in your book. Whoops. There is a really useful table in chapter 29. Yes, go to page 801 in your textbook and look at table 29.3. You should know these drugs. These drugs and what they're used for are really important. They're super common drugs, and a lot of your patients will be on them to treat this problem when a patient has heart failure. The angiotensin converting enzymes, those are your ACE, I'm sure you've heard those ACE inhibitors. That stops the angiotensin 1 from converting to angiotensinogen 2. That is a really important process for you to know. Now, if you flip back over and look at page 798 in your textbook, see this figure 29.1. This figure demonstrates the renin-angiotensinogen system and how that contributes to blood pressure and vasoconstriction and vasodilation. The ACE inhibitors work to prevent vasoconstriction and thus reduce afterload because it prevents those arteries from constricting. I think this diagram is a little bit confusing. And I have a better one. And I will post that and show you how this works. But it's really important for you to understand how this angiotensinogen 1 to 2 to renin to aldosterone system works. But I want you to know this table over here with the medications and how they work, because most of your patients are going to be on a combination of all these drugs. A diuretic, the thing with your patients who are on diuretics, now here's the problem. They need to be on the diuretic to reduce the afterload. They are typically on Digitalis to increase contractility, and they're often on a diuretic to reduce preload. You need to be very cautious because Lasix is a really good diuretic. It works phenomenally, works in the loops of Henle. The problem is it wastes potassium. It takes potassium with it. There's other diuretics like spironolactone and stuff that are potassium sparing. They hold on to potassium. So you need to make sure that you you know what diuretic your patient is on, because in the event that your patient is losing potassium because of their diuretic, as you know, potassium the heart is very sensitive to too high and too low potassium levels. So if that potassium level starts getting low, and the patient is also developing they're on DIG, and they can develop digitalis toxicity, which is why if they're on DIG, you need to monitor their DIG levels, because they can become toxic to it. In the face of digitalis toxicity and hypokalemia, patients can have start developing cardiac arrhythmia. So you need to be very careful when they're on these medications that you're following the potassium and DIG levels and monitoring their EKG. So the same thing can occur. This is the most common, and typically it's caused by an MI, but like I said, it can be caused by any of the cardiac disease that we've been talking about. You can also, however, have a problem on the right side of the heart. You can have a cardiomyopathy on the right side. You can have a valve problem over here. You can have an MI on the right side. It's not as common, but you can have that. So in the event that your patient has the right side of their heart is not working efficiently or as well, that is known as right-sided heart failure. The same concept applies. Your symptoms are going to be a little bit different. So, for example, if you have a patient who has, for whatever reason, an ineffective problem or an ineffective cardiac muscle on the right side, the same thing is occurring. So you've got your veins coming up here, subclavian vein, jugular veins, dumping into the right atrium. And now the blood is going to come down through our little tricuspid valve into the right ventricle. And again, this is your preload. Nobody really cares what the preload is on the right side of the heart. When you're talking about preload, you care about the left side of the heart. But both chambers, both ventricles fill up with blood during diastole, and technically both ventricles filled with blood. That's your preload. So again, when the right ventricle contracts, it's trying to shove its blood up into the pulmonary system. Well, the same thing occurs. So this gets all filled up, and then it starts backing up into the right atrium, and then it's backing up into the subclavian vein and backing up into these are the jugular veins up here. So that's why you will see jugular venous distension. A lot of times when people lay down, especially in the elderly, you can see their jugular veins. It really becomes a problem when they're sitting up. Like if you put your patient up at 30 degrees or semi-Fowler's and they still have JVD, you've got a problem. The right side of the heart is probably not working. And the other thing is then when all of this starts backing up, that's when you're going to start seeing peripheral problems. So you're going to see down here on the right side of the heart, you're going to see peripheral edema, because pretty soon it's going to all keep backing up in here, and the easiest place for it to go is to start like leaving the vascular space, going into the intravascular and the interstitial spaces, leading to peripheral edema. This is why it's important in your patients who have heart failure to assess their edema in the periphery to see if they're having pitting edema, because that is an indication that the blood or the fluid is not getting back to the right side of the heart like it should, and typically that's caused because there's a backup in the right side of the system. The other thing that you're going to see if you have right-sided heart failure, you're going to have an increase in your central venous pressure. And you'll remember your central venous pressure should be about 2 to 6. Some places will say 2 to 8. Other places will say 4 to 7. That number changes a little bit, but I think your textbook says 2 to 6. That's kind of the rough range. So when your CVP, your central venous pressure, starts elevating, your patient, one of two things is occurring. Either they're hypervolemic, they're for some reason they're getting way too much fluid, or the right side of the heart is not working and it's all starting to back up, and oftentimes it's both. They have hypervolemia and right-sided heart failure. But the treatment is the same. So you want to reduce the preload. You're going to want to put them on a diuretic so there's not as much blood going up into the pulmonary system. You want to put them on DIG because the right side of that right ventricle is contracting as well. That'll help increase the contractility of the heart. You're going to want to help get this fluid back into the heart. So simple things like keeping their feet up so that they don't have to work against gravity. That'll help reduce some of the edema down here. You want to keep them on TED hose. And all of these patients should, and depending on their underlying cause, should be in cardiac rehab, and that's rehabilitation specifically for the heart muscle. You have to be a little bit careful. These aren't going to be the patients that are going to go out and jog 5 miles right away, because as you exercise, when you exercise, you're increasing the efficiency of the heart, but you need to be careful to do it in such a way that you're not stressing the heart and causing more damage, especially after that heart has already suffered a problem. And in certain cases, like the cardiomyopathies or valve problems, you can never really get to a place of high-level cardiovascular functioning. Like that person who has a myopathy may only be able to walk short distances because you want them to stay healthy. You want good muscle contractions in their legs and stuff, but you don't want them working so hard that you're stressing that heart out. And sometimes even like high-level athletes, their myocardium gets very, very enlarged. But it's efficient. In an athlete, it's something efficient. If it's a cardiomyopathy, then it's an inefficient, dilated or hypertrophic cardiac muscle. So that's really the biggest problem. That you can, another thing besides having like rales, crackles in the lungs, dyspnea, if it gets bad enough, they have to be on oxygen, things like that. They can also have pulmonary edema. Pulmonary edema is when the lungs fill up with fluid very, very rapidly. It usually comes on very acutely. You want to prevent pulmonary edema from occurring, because pulmonary edema is kind of like this situation, but in the lungs. And when you get to the point where the lung tissues are filling up with fluid and inflammation, and then excessive fluid because of inflammation, that's what the body does when it is injured, is that it swells and has fluid from the lymphatic system. Those lungs can fill up very quickly with fluid and inflammation, and if you can't prevent it, sometimes it becomes quite an emergent situation. You've got to vent your patient, get your patient on a ventilator. So you really want to prevent pulmonary edema from occurring. The best way to do this is to be very astute and very cautious with how you are monitoring your patient. So you want to listen to their lungs very carefully, and if you start and watch your patient. So if you start seeing that the patient's is starting to get dyspneic, they can start getting anxious. They will start feeling nervous because they feel like they're drowning. You'll start hearing more fluid in their lungs. You need to intervene very quickly. They either need more diuretic, afterload reducer, definitely sit them up, try to calm them down, make sure that they're not doing something like they have a bunch of salt in their IV, like high levels of salt in their IV, that could be contributing to pulmonary edema. You might even need to switch them to a hypertonic solution to pull some of that fluid out of the cells in the intravascular space to help this problem, at least temporarily. So that is pulmonary edema is another problem that can occur in your patients who have cardiac problems. And then, so pulmonary edema is over. You'll see that in your book. You can read more about pulmonary edema. Pericardial effusion and tamponade, I talked about that in the last lecture. That's just where the fluid starts developing on the outside of the heart. And again, anytime your patient has an injury, it becomes inflamed and it gets swollen, because that's what the body does. It sends lymphs there to increase the healing process. So it's normal healing, but in certain situations it can create more problems, like with cardiac tamponade and pleural effusions and cardiac effusions, where they get too much fluid around there. And then they might have to also, in addition to these other things, do a pericardial centesis. And then obviously, worst case scenario is these patients have a cardiac arrest. And anytime your patient has some kind of a cardiac injury, they're at high risk for cardiac arrest. And that's when the electrical impulses of the heart stop. You can have pulseless electrical activity, where the electrical activity is still going. So you, like, if you hook them up to an EKG, you can still see the PQRSTs, but the heart's not doing anything. The heart just quits. So, but that's, you should know that, because you're all trained in BCLS and maybe even ACLS for what to do in the event of a cardiac arrest. Obviously, feel for carotid pulses. Carotid pulses aren't there. Annie, are you okay? Need some help? Start compressions. So that's, you all know that. So I think really that's the major ones with the, that is the major stuff you need to know for complications. And what I would really focus on here is knowing those drugs that I mentioned, because, yeah, I'd spend some time, just make sure that you know those drugs. Those are important drugs, and everybody and their brother's on them. And then I'm going to post something different about this renin-angiotensinogen system, because it's a good system to understand. But this table's confusing. Okay, that's it. That's all I have about that. Any questions? Yeah, I didn't think so. Okay, all right, see ya.